I'm John Stoessl from the Pacific Parkinsons Research Center at the University of British Columbia, and today is Thursday, November the 3rd, 2011, and I'm interviewing my mentor, colleague, and friend, Donald Calne. Donald, thank you for coming back to Vancouver. Welcome. I have a series of questions for you, and we can divert as you wish, but perhaps you could tell us about your early years and your education.
Well, I was very fortunate in my education. I think the most important feature was I went to Oxford University, and there the tradition, which I think should be much more widely applied, is that you can and should learn facts from books, and that you come here so that we can teach you to think. So we're not going to teach you any facts, but we're going to teach you to be critical. And I think that's the single most important thing I ever learned in life, actually.
Do you feel that that has changed, that has been lost as time goes on, or with different systems?
I don't know how things are taught in Oxford, but I would consider, since it was the 400th anniversary of my college there when I was there, and this had been going on a long time, it still goes on in Oxford now. Now, in terms of how widespread that approach to teaching is, I suspect that it's not possible to apply it widely, because this is a very privileged and luxurious, and I might say elitist situation, where you have a tutor in a one-to-one relationship with his pupil. And that is seldom possible now because of the load of people who are being educated.
Right. I'm just wondering what impact you think the easy access to internet information might have had on this approach to education.
Well, I think the easy access to information on the internet is something of a disaster, because I think that there's far more misinformation than information on the internet.
Yeah, well, perhaps we'll come back to that. Why and how did you become interested in neuroscience?
Again, it goes back to Oxford, where there was a tradition of neuroscience dating from Sir Charles Charrington. And there were two neuroscientists who taught me there, who I had the deepest respect and admiration for. Both of them unfortunately dead now, Charles Phillips and Bob Torrance. And I stayed an extra year to learn research from Charles Phillips, and I think that was a very important formative time for me, because he was an enormous enthusiast for research. He was really excited about every new observation, and that enthusiasm rubbed off a little bit on me.
So that was the end of medical school that you stayed on?
No, that was at the end of the preclinical phase, which I did at Oxford. I then went on to Guy's Hospital and did my clinical work there. That's in London.
Yeah. So for that research, you were actually in the lab, were you?
100%.
Yeah. And yet, for most of your career, you were in more clinically oriented research. Can you comment on the impact that working in the lab had on your critical thinking and application to clinically oriented research?
I found that working in the lab, that was of course 100% research, and it was very exciting, but very, very demanding. That is to say, in research I found, as I think everyone finds, that most of the time things go wrong, and it's only occasionally that things go right. It's a bit like fishing in a lake near where I live in Kamloops, where things are very hard to catch. So most of the research is hard, and if that's all you're doing, then it is really quite depressing most of the time when things are going wrong. If you're seeing patients and trying to help people, that is very satisfying emotionally. So I think that for me, the combination of doing some research and some clinical work looking after patients was an ideal outcome. I was very fortunate to be able to do that.
At what stage do you think you learned where to go fishing, so to speak?
There again, that was a stroke of luck, really, because after I qualified, I did a Wellcome Research Fellowship in London at University College Hospital, and Desmond Lawrence was the supervisor, and Gerald Stone was the neurologist who was interested in Parkinson's disease, and Desmond Lawrence was extremely interested in dopamine and brain pharmacology. And it was these two, particularly Desmond, who I was working with most of the time, who got me involved in research on Parkinson's disease, because a review was somewhat controversial, had just been published in Pharmacological Reviews by Ole Honikevitz on L-DOPA. And Desmond essentially said, well, this is a very interesting review. It looks important. Read it, and then we shall discuss what to do. And what to do, of course, with Gerald Stone was to start using L-DOPA in patients and see if we could confirm the early American work that was being done clinically, and the implications of Hornikevitz's paper, which was that dopa is converted to dopamine, which is depleted in Parkinson's disease, and therefore you can treat patients, get them better with dopa. And in those early days, it was very difficult to get dopa, of course, and I wrote to Ole Hornikevitz, and I was just a research fellow, never published anything, totally unknown. And he wrote an extremely detailed, friendly letter back, really helpful, telling me how to get hold of dopa for studies. And Ole Hornikevitz is an interesting and unusual person, because when he very kindly invited me back about 10 years ago, and I don't know, 40 years after that letter was written, to give a talk in Vienna where he worked, he had my letter.
Yes, I'm not surprised, actually.
He made a slide of my letter to introduce me at the lecture.
So the original, I think his paper that you just referred to, if I remember correctly, was in 1966. Does that sound about right?
Yes, yes.
And so that's when you got in your interest in Parkinson's disease.
Yes.
And then I think you spent more time with Gerald Stern after
yes,
that?
well, we were studying L-DOPA initially in Postencephalitic, just like Oliver Sacks, getting the same results.
Yes.
And then in ordinary Parkinson's disease, and then I went on to leave University College Hospital and work with Christopher Pallis at Hammersmith Hospital, and there we started using bromocriptine. And Christopher Pallis was probably the best teacher of neurology that I've ever come across in my life. He was a fabulous teacher and a tremendous person to be working with as a colleague, as a junior colleague. So all the way along, I was really very lucky.
So you've already partially answered my next question, which is who were your role models and heroes in the field? You've talked about Ole Hornikevitz and Chris Pallis. Any other people, or would you like to expand on their impact?
Well, I think I should come up to date a little bit and say that there are a lot of younger people who inspire my admiration and respect and would be heroes to me, and are heroes to me in a sense. And I would give as an example Zig Zolik, a colleague we both have worked with, who works at the Mayo Clinic and who is interesting as a researcher because he has one really outstanding attribute. He's a very modest, very bright guy, very quiet, and when he gets his teeth into a problem, when he recognizes it, he's like a bulldog. He will not let go. And that tenacity is very important in research. And it's very stimulating to see young people who have it really, really well developed and generate remarkable results because of that attribute.
Yeah, absolutely. I think we'd all agree with that. Now, you referred to the postencephalitic treatment, but in fact, I think you're being a bit modest, because as I recall, the inscription to the book Awakenings, in fact, thanks you for the advice. And I believe you were very early into the administration of levodopa to postencephalitic.
Yes, I think we were doing it in Britain, and Oliver Sacks was doing it in New York. And I'm not quite sure on the timing of the publications, but Oliver once said, I like writing books, I like writing letters, I don't like writing papers. So if there was any kind difference, I think it's because he was getting the same results and totally independently at the same time, but I don't think he wrote this up in the form of papers. Not early, anyway.
Now, you also like writing books.
Well, I'm not sure that I would say this. I have written books, but I'm not sure that I enjoy it.
And I won't ask you about your movie career for today's purposes. What do you feel are your most significant contributions to the field of movement disorders and Parkinson's?
Well, chronologically, and in terms of helping patients, I think the introduction of bromocriptine, which was the first dopamine agonist to be widely used for treating Parkinson's disease, was something that I was very fortunate to be able to do. And Desmond Lawrence was very important in relation to that, who I've already mentioned. More recently, and by more recently, I mean about 20, 25 years ago, I think that the work with you, where we were both studying subclinical lesions of the nigrostriatal pathway with positron emission tomography, and demonstrating for the first time that in human beings you can get subclinical lesions, and then with Brian Pate in monkeys it was possible to demonstrate subclinical lesions. I think that was also very interesting, because the whole fashion and interest in neuroprotective disease is predicated upon there being a reasonably long period of subclinical pathology. And of course, you with Zig-Zolek have gone on to extend that by looking at subclinical disease in patients with a family history where the gene is present but has not been clinically expressed yet. So I think that was an important contribution, but its real importance has really not become apparent, because there is, as I'm aware at the moment, no really effective neuroprotective treatment. When there does become neuroprotective treatment, then that detection of preclinical disease will be of paramount importance.
Yeah, I agree, and of course it's become an area of hot interest, and I actually, on my little cheat list here, had identified you were quite early on had expressed an interest in genetic studies together with Zig, and I think you saw the potential importance of those studies at a time when it was really not considered a very trendy thing to do. Of course, for the people watching this, some of them may not be aware of your role in the classification of dopamine receptors, which was a citation classic in Nature. Can you comment any further about that and the implications of that?
Well, that's very kind. And again, I'm very glad to have the opportunity to recognize John Kababian, who was the first author on that paper that we both published together. And that really stemmed from some very simple observations on the clinical effect of bromocriptine and its known pharmacological properties, together with some very detailed knowledge of receptor pharmacology, which John Kababian had. So by putting this clinical science and basic science together, it was possible to come up with that hypothesis, if you like, at the time. That's what it was.
And I think one of the other contributions for which you don't really take credit, but I know from my days as a research fellow you made a significant intellectual contribution to this, was the application of botulinum toxin for the management of focal dystonias that was, of course, led forward by our shared colleague Joseph Choi. But I remember from those days you were very quick to see the potential application of this. And it's, of course, revolutionized management of movement disorders.
Yes, well, that was really the application of work in another field. The ophthalmic surgeons were using it to treat weakened muscles that were overactive, relatively overactive in strabismus, and it was an application of that. And there were a lot of people interested in applying this. I think we were rather lucky to get amongst the first publications on it, and I think Joseph Choi was extremely skillful in placing the needle in the muscles concerned, detecting which muscles in cervical dystonia were primarily involved, and getting the botulinum toxin into those muscles.
So one of the themes that's coming out as we're talking is actually your love of taking problems from the bedside to the bench and then back to the bedside, which is, of course, the mantra of what we should be doing. Can you comment on the ease or difficulty of actually putting that into effect?
Yes, I'd be delighted to comment on that. The ease, for example, of administering bromocriptine to patients with Parkinson's disease in the days that we did that, which would be in the 60s, late 60s, very early 70s, the ease was amazing in retrospect. It was so easy to have rational responses to questions that would allow one to apply scientific principles to improving treatment in patients. Now I think it is amazingly difficult, and it's amazingly difficult because of the bureaucracy that has developed in relation to clinical research. It is so hard to do clinical research these days because of bureaucratic impediments for almost everything that you do, from not only new medications but new drugs for tests. We were talking about PETs, positron emission tomography, earlier today, which is another good example. And it's a great shame that new treatment is, I think, significantly held back by an excessive caution, an excessive power that is given to bureaucrats.
We could talk for a long time about bureaucratic challenges to our work. Can you talk a little bit about some of the great scientific challenges in your career?
Well, the great challenge is what is the cause of Parkinson's disease, and to some extent that should be reformulated because of all the interest and the achievements in the genetic field, is what is the cause of Parkinson's disease, that is to say, Parkinson's disease where there is no recognized genetic contribution, sporadic Parkinson's disease. And even the simple question of whether this is caused by unknown environmental factors or a factor, or whether this is caused by genes that have not yet been discovered, is not a question that we have an answer to now. So I think this is the huge problem for your generation.
Well, that leads nicely into the next question, which is where you think the field is headed in the years to come.
Well, I'd like to say the discovery of the cause of sporadic Parkinson's disease, but it's a tough problem, and I think that the solution of such problems is very unpredictable. Often solution comes from quite unexpected directions. So I think it is logical to work on a fairly simple hypothesis that the pathogenesis of Parkinson's disease may be similar in genetic and sporadic forms. So that even if you don't know the etiology of the sporadic forms, if the pathogenesis is the same in the genetic forms, and you can analyze the pathogenesis, which we're making a lot of progress towards from looking at gene products and so forth, then you may be able to interfere, modify the progression, delay the evolution of the clinical symptomatology in both genetic and sporadic Parkinson's disease, if indeed they do share a pathogenesis.
Yeah, I would certainly agree with that, but you've actually made me think of another off-script question, if I may, which is the implications. I think what you said is that often the insights will come from unexpected areas. So can you comment on the approach to research funding and the types of approaches that government take to funding, and whether it should be more targeted or less targeted, given that some of these insights may come from unexpected directions?
Well, I think the worst aspect of research funding is bureaucratic decisions on what needs to be done and what is going to be politically desirable and response to pressure groups. I think that is the worst aspect of research funding. And the best aspect of research funding, which is difficult, is to give money to people who have good ideas. And that needs very critical evaluation by independent peers. And so I think the recognition by administrators that scientists are the best people to decide where money should go for science is a very important one, and that politicians are not the best people to decide this.
Can you comment on the relative roles of fairly independent yet brilliant investigators versus groups of people working together?
That's difficult. I think there is perhaps an overemphasis, because it sounds very democratic and very attractive politically to have people working together. But I think that in fact the contributions often do come from individual scientists who've got an idea that they pursue on their own and come up with it. I mean, obviously penicillin is historically maybe the best example of this. But I think this is the way that science usually goes.
But you, on the other hand, built a team of people.
Well, I think if you're using a technology that requires different expertise, and particularly a technology that, if you're working as a clinician with a technology that you don't really understand but you need, then you must have a team.
Yeah.
And I think that probably applies to all aspects. I mean, in the case that we were both involved, the technology of imaging with positron emission tomography is something which is very tough for a clinically trained neurologist to acquire, because it's too much to learn. So I think you need to work together, and that's another area, incidentally, in which I've been very lucky, because the collaborators, the team in the studies with positron emission tomography that we undertook at UBC, University of British Columbia, this was a potential situation for a lot of conflicts, but it was actually a pleasure to work with the colleagues in PET here.
Absolutely. What advice would you give young physicians and scientists entering into the field of neuroscience and Parkinson's these days?
It's difficult to answer that seriously, because it's so open to a facetious response. I think if somebody's determined to do research, then the most important thing, and I'd like to, incidentally, take this opportunity to give credit to my wife, who's been my working colleague for many years, because she has this statement at the end of all her emails, is that you have to be very critical, and she quotes a saying of Buddha that you should not believe what you hear, you should not believe what you read, not even if I say it or I wrote it, unless it fits in with your own common sense. So you should be critical of all the background work that's been done in science, because actually most of it is probably wrong. And you should have an open mind and a critical mind to take what you find the facts and apply them with your reason to a solution of the problem that you formulate. So I think an independence and a critical independence, it goes back to what we were discussing earlier, that the one really valuable thing that I learned at university, that I was taught at university, was to be critical, not to accept everything that you're told.
Absolutely. Now, there's been a lot of concern, certainly in Canada and I think elsewhere through the world, about our failure to generate significant populations of clinician scientists these days, and in fact, there are many people who believe it's a dying breed. Are there things you would do differently to foster that type of inquisitiveness?
Well, I think here I agree with the sentiment behind your statement very much, that there are not enough clinical scientists. I think maybe the role of the clinical scientist is not recognized sufficiently, and therefore there is not enough encouragement in terms of funding to appoint people in clinical science and to support them. And I think there should be much more effort to encourage people, probably the clever young clinicians. You've got to have a clinical training first. The clever young clinicians to come through, to get them interested, to get them to do a year or so in science and see if they like it, see if they enjoy it, see if they're good at it, and then to provide them with the funding required to do the work.
Do you feel we have the same role models now that were in place when you were training, in terms of clinicians, prominent clinicians who are also engaged in research?
I don't know. My general feeling will be that we don't have role models sufficiently. We don't have them now, we didn't have them then, and it's because it tends to fall between the two. The clinicians have their own role models, the basic scientists have their own role models, and because the clinical scientist has not been encouraged or fostered, supported sufficiently as a profession, if you like, as a career, I don't think they've really established their role models well enough. I mean, you've got to go back in history to look at the great clinical scientists.
Yeah. The next question is perhaps a bit nasty. If you could wind the clock back 20 years, would you do anything differently? This will require a careful response because it's approximately the time that you recruited me back to Vancouver.
Well, I just think I've been very lucky, and that's also a very useful attribute. So I don't think there's anything I would change looking back. I think I've been very fortunate.
Good. Did you experience any bias or barriers during your career development? And do you feel that younger colleagues today face similar or different barriers?
Well, yes, and this goes back to the issue of critical thinking. And I think the barriers may come from drug companies who are trying to develop and sell drugs which may or may not be better than drugs that are currently available. And I think this can also come from large consortiums of investigators who may develop a position which involves so many of the workers in the field that it's almost impossible to be critical of this position. And if I can give an example of that, there was a study some years back on the use of deprenyl as a neuroprotective agent. And there were a group of us here who were critical about the Datatox study and did not think that it fitted in with our own common sense, the Buddha criterion. And one of the young clinical scientists, who is not at UBC now, very clever, very good individual, I said to him when we were going to publish our criticism of the Datatox study, you have contributed to this paper, but I want you to be aware of the fact that this is quite critical of a lot of powerful clinical scientists in neurology, and I think your name should be on this paper, but I want you to approve of that before we send it in for publication. And he decided he did not want his name on the paper because he thought that by disagreeing with a number of powerful but perhaps less than expert clinical scientists, his career would be impeded.
Well, you have a history of challenging established truths, I think, and you've been quite successful in making people, even if that doesn't persuade everyone at the end of the day, I think you've made people stop and think about what they're reading and what they're hearing. That was one example. I think there have been a number of others, in fact, over time.
Well, you're very kind.
Are there any things that I haven't brought up that you would like to discuss or raise?
Well, I might say in relation to your last comment that the single word that would describe me in that context is troublemaker.
The pharmacological term would be antagonist. Well, thank you very much. It's a great pleasure to do this. And actually, I asked about role models because I think we don't make enough of the importance of role models in our careers, and you've obviously been a major one for me.
Well, you're very kind, John.
So thank you.
You'll be for many others.